I'm going to say congratulations to Dr. Donald Trump, who arranged for 9 pharmaceutical firms to lower the cost of drugs. It was the first time I've been able to compliment him on something. So give credit to where it's due. He got 9 CEOs of major pharmaceutical companies to lower drug prices. So I have to give him compliments on that. But now to our current business. Our program today was originally named Stop Blaming the Victim, but we've had a change. We have a joint presentation by Dr. William Lawson and Dr. Edwin Chapman. We all remember both. They both presented multiple times. Dr. William Lawson is professor of uh, psychiatry at George Washington University. Edwin Chapman is a schoolmate of mine who is a major figure in the world of substance abuse disorder. And they're going to discuss issues of substance abuse disorder and the pharmacology of that. Is Dr. Lawson on yet?
Yeah, I'm here. Can you hear me?
Yes.
Okay, now, are you able to show the slides?
Did
Hello?
you send?
Are you able to show the slides or do I need to show them?
You need to show them. You didn't send them to me.
No, I did, but okay. Yeah.
We can hear
Okay.
you, Dr. Lawson. We can't see.
Okay.
You want Dr. Chapman to start first?
Yeah, I'll get it. I think I should get it in a second. Um, I just want to make sure, I mean, I can get it, but can I transmit it?
You're trying to send the slides or you're trying to show the slides, Dr. Lawson?
Yeah, I thought I sent them to you, but apparently it didn't get through. Let me just see, go to share the screen.
Dr. Chapman has his slides up.
Yeah, I'm sure he does. He's ready to roll. So, okay. Just tell him to try to stop. Give me time to speak something after he finishes.
So, Dr. Lawson, you want us to just have Dr. Chapman go ahead?
Well, I had it up a few seconds ago. Just try it one more time. And then if I can't get it this time, go right ahead. Yeah. Okay, can you see, is that on?
No, Dr. Lawson, we can't see you on camera and we can't see your slides either. So why don't we just have Dr. Chapman go
So
ahead?
why don't we have, go ahead.
Dr. Chapman, welcome.
Oh, wait a minute, hold on.
Yep, now we're seeing the screen. Whoever's screen is not connected to the network though.
Something just
So I'm not connected, yeah. So Chapman is on, that's great.
okay, so can you stop sharing your screen, Dr. Lawson? Let's get Dr.
Okay,
Chapman going.
I'm not sharing. Sure. But stop speaking.
Dr. Chapman, are you able to share your screen?
Okay, I stop screen share. Okay.
If we can get Dr. Chapman to be unmuted and get his,
Because I
Dr.
can
Chapman,
see-
you're muted. You're muted, Dr. Chapman.
Yeah, I can see Dr. Chapman. Can't hear everybody.
Dr. Chapman, can you hear us? Can you hear us?
We can see your slides, but we can't hear you.
Okay. Okay, I think he can hear us.
You make a hand signal to her.
Dr. Chapman, raise your hand if you can hear us. Okay, so he can't hear us.
All right, I unmuted. So you can
Okay.
hear me?
I
Yeah.
can hear him. I can hear
Can you
him.
see, can you see the slides?
Yes.
Okay. All right, so I'm going to talk about precision dosing of buprenorphine, which has been a 10-year project with us with the advent of the fentanyl epidemic. Let's
Deliver us from evil, for thine is the kingdom.
My only disclosure, I do speak for Braeburn Pharmaceuticals and Brixadi. So we're all aware that we've had a tremendous change in our healthcare system at the CDC, HHS. I won't go into the details, but everybody is aware of the past 10 months. So these are, this is an outline that Dr. Maxey created the last time I talked. And it's very apropos for this discussion because now we're well into the opioid epidemic, pain management, and the new administration and the impact that it's having on all of us. I won't go into the details, but we're all very much aware that with the restrictions that are coming to Medicaid, the dramatic changes in supplemental payments that a lot of people are going to lose health coverage, and particularly people who have mental health and substance abuse problems. So from a structural standpoint, we know that we're only 5% of physicians. And when we talk about mental health and psychology, that only 4% of psychologists, 2% of psychiatrists are African-American. This is a slide from 2013. Dr. Lawson had the idea that he wanted to merge substance abuse, mental health, and primary care. And he invited me back to the faculty at Howard University when he was chair of psychiatry. And we put together this model, including telemedicine. So we know that the US is very different from the rest of the world. We have perhaps the worst healthcare system in the industrialized world. But when we look at substance abuse and overdose deaths, we're all the way at the bottom. We have 324 deaths per 100,000. And you can see, compared to the rest of the world, this is just horrendous. This is a talk that I gave on PBS a couple of years ago, indicating that African Americans now have the highest per capita overdose rate in the country. And that occurred somewhere between 2017 and 2019, primarily due to fentanyl, heroin to fentanyl in our street drug supply. So this is Washington, D.C. This is another article talking about the overdose death rate in the African American community, and particularly impacted Black men born between 1951 and 1970. So those are people who are now pretty much in their 70s. And we can see, again, the impact on African American males compared to everybody else. And this is not just a DC problem, this is a national problem. So there has been a dramatic decrease in opioid prescribing in hospitals, but you can see that this has not impacted the street drug supply. And then we have other additives like xylazine, which came into the market somewhere around 2020. And this just shows the overdose death curve in Washington, D.C. We went from 20% fentanyl in 2015 to 93 to 98% in 2023. We have had a decrease, but the reasons why that are multiple, some because of the aging population, and you'll notice that those above the age of 50, because of the fact that they're dying out for other reasons, have decreased the most dramatically. So we have a problem again with just identifying patients and then treating patients because our insurance companies use biased algorithms, which in many instances underserve our patient population. So with Project 2025, we all know the impact of that on this whole process. And this is just a schematic drawing, really showing all of the inconsistencies that we're seeing from the current administration. Dr. Francis Collins, the former head of NIH, put it very bluntly. And this is a statement from Arthur Kaplan, really refuting the whole idea that DEI is not important. DEI is the very core of what we do. So diversity matters, truth matters, genomics matter in establishing different groups of people and how they respond to drugs and vaccines. So attention to DEI allows researchers to identify differences in safety, efficacy between groups early on in the testing process. And this was a talk that I gave in Philadelphia back in 2018, and again pointed out the fact that we have an apartheid healthcare system, and the fact that some people get insurance and others don't all plays into that. The fact that patients on Medicaid and patients in certain communities are disenfranchised, and it creates large gaps in healthcare. The ideal system would be France or Portugal, where you have universal healthcare. So this is, again, reversing the scheme that you saw with Donald Trump. And that's really the basis of all that we're going to talk about going forward. So this is a profile of my patient population. In 2015, you can see that at that time, the average age was 53, 40% females. Incarceration was treatment for substance abuse for the most part. 50% of our patients in 2015 already tested positive for hepatitis C, 50%, up to 95% had a mental health diagnosis, but 50% primarily suffered from anxiety and depression. About 10% of our patients at that time tested positive for HIV, 90% smoked, and you can see that 20 to 25% were homeless. This is today's profile. And again, you can see that now that same population, the average age is 61, ranging from 24 to 84. But the preponderance of patients now are in their 60s, and most don't make it to the 70s. So this is the complex that we're dealing with. I often use Porter's five forces to really show that while we strive for outcomes in healthcare, we're also battling a corporate system that is more interested in return on investment. So when you really study Porter's five forces, you can see that the outcomes for the patients are not necessarily the best. So we have a structural problem in terms of just having access to providers, but we also have a regulatory problem. And Dr. Helena Hansen pointed this out over 20 years ago, that one of the 3 FDA-approved medications that we use to treat opioid use disorder, buprenorphine, was not readily available in our community. And that was because of the fear that this Schedule III drug would be changed to a Schedule II drug like methadone and create more restrictions. So they really didn't want this medication used in our community and our patients who were most often troubled with street drugs. So in New York, where she was at that particular time, most of the patients were treated with methadone as opposed to buprenorphine. And we pointed this out on a panel with the American Society of Addiction Medicine back in 2022. So only about 3% of buprenorphine prescriptions in 2019 were written for African-American patients. And that problem has persisted. We also had a problem with dosing because the FDA had capped dosing for buprenorphine at 24 milligrams. Well, they really didn't cap it, but they said that there was no value of dosing above 24 milligrams. So this is a slide actually from 2023, and you can see that there are only about 5 states or 6 states that you could dose above 24 milligrams, and those were California, Oregon, the state of Washington, and New Jersey, New Mexico, and Nebraska. So we did a study with the Howard University College of Pharmacy, actually 2 studies that were published that showed that our small cohort of patients who were generally heroin to fentanyl patients actually did better on doses of buprenorphine above 24 milligrams, up to 32 milligrams. And we published those. We reported it multiple times. I was on a panel with the now president of the AMA in 2023. And again, there was a lot of pushback at the beginning of the year. But as the year went by, in May of 2023, one of my patients who was on 32 milligrams overdosed and survived. The problem was that he was on United Health. He was on Cigna, and he switched to United Healthcare, and United Healthcare capped his dose at 24 milligrams. Fortunately, he survived. Washington Post reporter was tracking this patient, and on that same day, we were able to contact United Healthcare and get his dose increased back to 32 milligrams. So this is very important because it's really the beginning of what we already knew, was that different patients needed different doses of medication, but the subset of patients that the FDA was looking at was not our population. So I was involved in a listening session with Samson, NIDA, and the FDA in December of 2023, and this slide was presented that showed the gray area are patients who were on doses of buprenorphine above 24 milligrams, and those patients had fewer hospital visits to the emergency room and hospitalizations. So that listening session was published, and this is a summary. I've sent you a copy of it, but this was a statement that I made, and a statement that the then director of the Center for Substance Abuse Treatment, Dr. Ingvild Olsen, stated. Now, subsequently, on a panel in 2024 with Dr. Olsen and Senator Ed Markey from Massachusetts, whose wife happened to be a psychiatrist, and that particular panel was an effort to increase access to methadone. On the left-hand side is the reporter Lee Thatcher, who subsequently published an article on the fact that NIDA, as of September 25, 2024, actually increased the dose of buprenorphine, and that was followed by the FDA in December. So this is a slide of one of my patients, again, that was done by the Howard University College of Pharmacy. It was done particularly to show the difference in payment and dosing from our insurance company. So there was no standard of care. This particular patient not only tested positive for fentanyl, but also tested positive for xylazine, PCP, opiates, cocaine, and amphetamines. And she happened to be on sublingual buprenorphine, which only showed up on one occasion. Following that, or at the same time, studies were being done on injectable buprenorphine, and the injectable buprenorphine studies compared the sublingual dose to a weekly and monthly injectable form. And this is just an excerpt from the paper. In the upper right-hand corner, you can see that they use different doses, both sublingually and with the injectables. And that tells you that everybody does not metabolize these drugs the same way through the liver. So this is just confirmation that it was not that our patients were diverting their sublingual medicine, but we found with the injectables that different doses were needed. Now, this is the same patient that I showed you earlier with the Howard University study. She has now been on injectable buprenorphine. She went from 32 milligrams sublingual with all of those positive urines for opiates and cocaine and amphetamines. Today, she's drug-free. And what that tells us is that perhaps the drug supply that she had was also contaminated with multiple other drugs. So by getting her now on the injectable, she always tests positive now for buprenorphine and negative for other drugs. She actually gained 60 pounds in the past year. So this was a dramatic example of what getting patients on the right medication can do. So we often talk about patients being totally drug-free, but we also see progress when patients are not totally drug-free, but on methadone or buprenorphine. And this is just an example. So using a harm reduction model, if patients are using less often, they may continue to test positive for drugs, but they're less likely to get AIDS, hepatitis. Their degree of criminal activity is decreased significantly. So this is a study that really shows the impact on drug treatment in various ways, and we call it wrong pocket savings. So if a patient is stable on medication for opioid treatment, they're able to work, they're able to take care of their families, criminal activity goes down, and their children are less likely to be in foster care. And surprisingly, sublingual buprenorphine or methadone per patient per annum saves $271,000. I'm going to say it again. Methadone and buprenorphine sublingually save $271,000 in cumulative costs. So if you now multiply my 160 patients on buprenorphine times that figure, it comes somewhere between $30 and $40 million a year, just treating 160 patients. So this really just shows that 25% or less patients who actually need to be on medication for opioid use disorder are on treatment. And of course, Black patients are even less. The numbers are somewhere around 10%. So what happened after COVID? I think Dr. Lawson will be able to tell us. He's got a new book coming out called Racism, Health, and Resilience in a Post-Pandemic World. But we know that we are in a dire situation with the current administration. Now, this is an article from 2016, and we've known for a long time that only that 95% of our medications that we take are tested in a very small, generally 5% white males, which means that our genomic profiles are missing. And that may account for much of the information that we were able to get early on from our small patient population, realizing that our survivors needed those higher doses of the buprenorphine. So again, we're talking about the importance of having genomic information and matching patients to their genomic profile and medication. So we're now talking about moving into the era of precision medicine. We're talking about pharmacogenomics and the future of medicine, and the fact that we need to have our patients tested because, for the most part, they are taking medications that are not directly geared to their genomic profile. And these are some of the values going forward that we expect to get from pharmacogenomic testing. It's already been proven with a number of mental health medications and pain medications, but we want to expand that to all diseases: diabetes, hypertension, cholesterol. All can benefit from this. But we need to have genomic profiles, not only from the small subset in this country, but from the rest of the world. And finally, this is kind of a summary of where we might be going. If China is building kiosks that people can go to and tell their symptoms and give a blood sample and have AI make a diagnosis, what would happen if you put their genomic profile in there and that genomic profile then told them what medication they needed. So we're really on the precipice of a tremendous change in healthcare, financing. This future is going to be the key, and this is just an executive summary of one company's move into that financing area. I'm going to stop there and turn it over to Dr. Lawson.
Dr. Chapman, I thank you so much. Let me ask you one question before we transition while Dr. Lawson gets up his slides. We have a war going on in Venezuela. We have products coming from China. We're afraid to bomb them. But what can we do about the demand for these drugs? Is anybody working on that? Now, we treat it, but what do we do about lowering the demand? What does that process look like?
So I'm glad you asked that question. Our emphasis, again, has rolled back to the old Ronald Reagan, just say no to drugs, with trying to intercept drugs. Now it's even more difficult because we've moved into the synthetic era. And you mentioned Venezuela. Venezuela primarily would be cocaine being exported to Europe, not to the U.S. So the fact that they're intervening in with these boats from Venezuela makes absolutely no sense in terms of the fentanyl market. So these are the kinds of inconsistencies that we know better, and we have to face and inform our community so that we're not going down that road. But at the same time, the fact that Trump is doing all these stupid things is an opportunity for us to get ourselves together and use the brilliant resources in our community and invest in those resources and do the right thing.
Okay, thank you so much.
Dr. Maxey, I want to ask if we can, I guess, call an audible. We only have about 20 minutes left, and I have about 25 questions for Dr. Chapman, because what Dr. Chapman is talking about is so important and so impactful. My question would be, could we hold Dr. Lawson's part for our next Black Health Trust? Because Dr. Chapman is feeding us a lot right now, and I think we dig into it for a minute. Is that possible, Dr. Maxey, Dr. Lawson?
It's fine with me. Dr. Lawson, is that okay?
Fine with me, because I think a lot of what he's saying and the questions that he raised are extremely important. Don't give me more time, but I have no objections whatsoever. I think, and the question that you have in terms of how do you reduce demand, I mean, that's a whole session in and of itself. And I hope we can build on that, because that's ultimately how we're going to try to address these problems.
Go ahead with the question, Dr. Walks.
Okay, so thank you, Dr. Lawson. Thank you, Dr. Maxey. Because I know that we can't squeeze Dr. Lawson into 19 or 20 minutes anyway. So let me say this, Dr. Chapman. My question along kind of complements, I think, Dr. Maxey's question. When I look at the work that you do, because I know some of the work that you do, working with the Leadership Council for Healthy Communities, looking at building the community. Just because we stop someone from using drugs doesn't mean that we have impacted the other parts of their lives.
Oh, you see,
And
okay.
This sort of wrong-headed savings and how we don't look at the total picture of the person, getting them back to work, getting them to take care of their family, keeping their kids out of foster care. Can you talk a little bit about that, the other aspects of what you do that directly impact the people that we're trying to talk about and understand better and help?
So I'm so glad you asked that, because again, the Leadership Council for Healthy Communities is a network of churches in the Washington metropolitan area that was put together officially about 15 years ago. And we were working on AIDS at the time, but as time went by, it was evident that AIDS was connected to other things. Like substance abuse, like homelessness, like not having a job. And so we pivoted and got the pastors and the lay people that we were working with, and you were part of that, to understand just what you said, that getting somebody off of drugs, we also needed to get them housing. Safe housing. We needed to get them, make sure that they had insurance, make sure that they were getting counseling. So all of those components, the so-called social determinants of health, we now know account for 80% of health outcomes. So we've expanded that and now have grants from the DC Department of Behavioral Health for seniors above the age of 55 with substance abuse problems, with returning citizens with substance abuse problems, so that when they come out, we can be the advocates to make sure that they get insurance, that they get housing. And we're also building a workforce. We're building peers who are able to work with these individuals to walk them through the very complicated healthcare system.
Dr. Max, I just want to emphasize one point that both Dr. Walks and Dr. Chapman are noting, and that is that right now there seem to be two dynamics in terms of understanding substance abuse. One is that it is a problem of people who are evil, and you have to destroy them. And the other is that it is a disorder that can be treated. Unfortunately, we have a lot of resources in terms of disorder that cannot be treated, which we're trying to blow people up, lock them up in terms of prison. Is one of the biggest factors that led to the overrepresentation of African Americans in our correctional system. And yet, at the same time, as Dr. Chapman noted, another approach, an approach that LCHC is doing, is that recognize that the drivers of very much our life circumstances, mental disorders, as well as people being bad. And we now have ways of treating people with mental disorders. And we found that, in fact, if you treat depression in people who are former opiate abusers, they're less likely to do it again. Also, panic disorder. We demonstrated that half the people in our primary care clinics at Howard University had post-traumatic stress disorder or depression or both. And this has been replicated at UCLA and several other places as well. So a lot of our folks have dealing with life stresses in ways that are self-destructive because the only answer that they see is the use of street drugs or equivalent agents, or even some prescription drugs inappropriately. If we can address these issues, I think we can cost effectively reduce the problem of addiction.
let me bring up a question. Is Dr. Hines on, first of all?
I am.
Okay.
Dr. Hines is
we
on
wanna
and she
go to
is
you.
forward.
Let me ask
so
you a
she got
question.
some questions.
I'm a pharmacologist, as you know. And years ago, I wrote a paper on this very subject, precision medicine. I know now we've talked about drugs that can potentially stop certain things such as Alzheimer's disease. We've talked about drugs that can prevent strokes, drugs that can prevent heart disease. Is there any effort being made on drugs that can prevent drug abuse through the
Yes.
endocannabinoid system or whatever there may be? Is there anything that we can stop the demand and the mental illness?
The good news is yes. We just did a study, multi-sites, multi-million-dollar studies using buprenorphine, showing that not only does it prevent people from developing cravings, but all the associated social events that associate homelessness, incarceration, and so forth.
I'm not talking about people who already use drugs.
And no, and let's go further. We've also had several agents that are now being used to try to prevent the use of drugs. Some of the anticonvulsants, for instance, like lamotrigine, if you give them to people who are in distressful situations, they are less likely to turn to drug abuse in the future. And you mentioned some of the other issues that you talked about looking for pharmacotherapy. We now have drugs that are effective in turn. In fact, we have 2 approved drugs for treating suicide. Again, these are agents that have been shown to actually not only change physiological dependence, but also change the preference or the decision in terms of how you deal with personal problems.
Let's recognize our young, very sharp co-host, Dr. Hines.
Thank you. And Dr. Chapman, that was a very intense and in-depth presentation. You brought out a really interesting stat about 250,000 per case cost savings. And having worked in spaces where payers were the client and the emphasis on ROI, what is the overall time frame to achieve that saving? And then my second question is, because we've, and this is my slightly cynical question, who are the systemic profiteers off of continuing our substance abuse problem as a nation?
Well, absolutely. The fact that we're talking about taking people off of Medicaid if they don't work. And I've read some of the articles from the conservatives and their rationale. Oh, they're home playing video games in the basement. They should be out getting a job. Well, you really don't know who that person is from a mental health standpoint and from an environmental standpoint. And we always talk about a pair of ACEs, the so-called adverse childhood experiences, adverse community environments. And we know what's happening in our community, that we have a traumatized community, and only we can address that. And that was part of my whole discussion in Philadelphia in 2018, the fact that our population was systematically pushed aside for 4 centuries, and we're just seeing the same thing all over again. So we're going to have to take on the responsibility and really change some minds in our own community, because there are some people in our community that think that well, I made it, they should have made it, and that's why we have to think more in line with some of our great thinkers like W.E.B. Du Bois, and the fact that if we're going to be the so-called town the 10th, we need to act like it, and we need to look towards the masses and build our own leadership and remove those people who are in the way. Now, when it comes to the insurance companies, I actually was removed from one of the insurance companies here in the District of Columbia because I complained about the medication, the proper medications, whether the patients were on generics or getting branded. And that's another issue I didn't talk about. But we also found that there's a significant difference in our patient population when it comes to branded versus generic buprenorphine, for one. So pharmacogenomics is going to be critical going forward because we're so, we're so much alike. We're 99.9% alike, but that 1% can make a huge difference in terms of medication.
You raised a question for me, Dr. Chapman. Can you explain? I know you have a guest on the call. What is pharmacogenetics and what can we learn from the testing that we can do genetically on that?
So again, we know that man originated in Africa, and so if we're going to get the whole genome, so to speak, we need to collect information from Africa and then use that as a basis, and then and compare it to what is currently being done. The fact that only 5% of or most of our drugs are tested in white males means that you're leaving out 95% of the population. So we're taking medications based on an incomplete data set, and that's what we're trying to rectify. And we're not just talking about substance abuse, mental health. We're talking about everything that we take.
Let me go a little bit further. About 2 years ago, I gave a lecture on CKD, chronic kidney disease, and it was based upon something called APLO1, which is a gene variant that comes from West Africa. And they have developed now treatments for that gene mutation to prevent kidney failure. I'm harping on this a minute. And I agree that if we go back to testing our people and find where these faults are that lead us to the characteristics that allow this racism and these evil things happening to make us less vulnerable and possibly treat them better, do you think that would be something good we can do?
Absolutely. That's why you and I at this age and Dr. Lawson continue to do what we do, because this is our legacy. This is something that we have to do. It's not something that we should do. It's something that we have to do. And this is the best time to do it because we have all of these other forces that are making absolutely no sense, and which again gives us an opportunity to bring the truth to service.
So what I'd like to offer is that, and I'd like Dr. Walsh to comment on this as well. A couple of years ago, we did a summit on COVID-19 and vaccines. And we had the chief of medicine at Downstate University be the leader of that. I'd like to see us at Black Health Trust host a summit on dealing with problems related to our heritage and problems related to the evil society that we're living in, and include in that how to deal with the tendency for drug abuse to solve some of these problems. We can get the right title together, but maybe we can do that in the next 3 or 4, maybe 6 months, and maybe even do it at the next National Medical Association or Association of Black Psychiatrists, something like that. What do you think, Dr. Wilkes?
I think that is a fabulous suggestion. Certainly us digging more into how we can move forward in a way that makes sense is fabulous. We had a hand up earlier from Orlando Davenport. I don't know if that was your guest, Dr. Chapman, but certainly that hand went up, and I think Dr. Hines has another question as well. I only have
There
17
was
more
there was
questions.
a Dr. Veal on too, I think.
Well, while we're sorting that out, can I ask very quickly, do you feel like in the training spaces, the role of pharmacogenetics and the availability of testing is becoming more mainstream? Because to your point, it's the outliers who really benefit the most right now from those, like the people who don't respond to the conventional things just yet. And those are the same people who are being excluded. So are we moving in that direction from a training perspective even, or in the teaching institutions and in the cohorts of the establishing themselves practitioners? Is I'm not in touch with residency programs and younger folks, emerging doctors like I used to be.
Dr.
That's
Chapman?
probably a Dr. Lawson question, because Dr. Lawson is still in the trenches there, working with the young folks.
All I can say is there's a group in Michigan. We have a depression group, and part of that is to promote genomic testing. Unfortunately, the problem is with this is that we just don't have enough data from our folks. So most of the commercial companies are just not pushing it because it's not been very useful and profitable for them when we're using our folks. If we can get that database expanded, then maybe we could have something.
And in the same vein of the topic we were talking about before, then how do we, I mean, again, big ideas, right? But the space of yet another technology, yet another advancement that we may easily be pushed out of really getting the benefit of.
Yep.
Yeah. Is Dr. Veal on?
I do see Dr. Veal, and we still haven't been able to get Orlando Davenport unmuted,
Okay.
and Dr. Veal is also muted.
Yes, hello everybody. How you guys doing?
Okay.
Yes, this is Troy Veal with PhD Laboratory. How you guys doing?
Good.
Yeah, how you doing?
How you doing, Dr. Maxey? I was the one that came to your house about 3 months ago, well, back in April, speaking about pharmacogenetics. And just so happened in my research or in my studies, I ended up bumping into Dr. Chapman about 2 months ago. And he and I has been conversating about PGX. So we do have the most comprehensive test in the market today. We consider that we have the most prolific test on the market today, covering over 20 therapeutic areas, which include psychiatry, pain, dermatology, ophthalmology, endocrinology, oncology, all the ologies. We have all those a part of our panel. And I have my chief scientific officer, Dr. Jim, that actually works in our laboratory. And he is the one that's very familiar with what you guys are talking about today. So with our test, I don't think there is a test that the big boys, the LabCorps and the MACO can really, contest with our pharmacogenetics testing at this time. So linking up with Dr. Chapman and speaking to you about 5-6 months ago, pharmacogenetics we feel might be the closest thing we can get to the answers that we need, because we could test,
How can we help?
Yes, sir.
How can we help you?
Well, that's the thing that Dr. Chapman and I have been talking about, moving in the right direction. I think he has some great ideas in terms of getting some data started within the next, within this year, testing people that look like us, testing people that definitely, can benefit from what we're doing, and creating this data knowing this data, we have a more sufficient way of knowing which direction we should head.
Are you gonna be at the National Medical Association in July?
I absolutely will be.
Okay,
Okay, so Dr. Maxey. All right. It is the top of the hour. I have on my Christmas green. And I just want to say, I think we need to actually schedule a program to explain and talk about pharmacogenomics, because it is so important that hitting a couple of questions is, I think we need to do that. We have to come back for Dr. Lawson's piece. And I really would love to have a session where Dr. Chapman digs a little bit more into the LCHC work and the community aspects with the social determinants of health that is such an important part of what he does. We got a lot of work to do.
We'll plan
and we can't do it in 30 seconds.
Okay. So let's ask for final comments, short final comments for today, and we will definitely get a schedule together. Dr. Chapman, thank you so much for an eloquent talk to us. Would you care for final comments?
Well, let me just say the way we were able to accomplish what we did with Northland, I converted my office to electronic records 10 years ago. And at the same time, the Howard University has a College of Pharmacy, the only College of Pharmacy in the District of Columbia. And we allowed the professors from the College of Pharmacy and their students to review my records. So instead of getting a notice 2 or 3 months later from an insurance company that you got a patient on this drug or that drug, and there might be these students went in and pulled my notes, looked at all of the labs one at a time for over 150 patients, focusing on opioids. And I think that connection, and in April at our Region 2 meeting, there was someone there who, when I made a presentation, talked about the uniqueness of that model. The fact that if you have community doctors and you have a College of Pharmacy going into your records and helping you, that it's a total paradigm shift in terms of the information that you're going to get.
Excellent. Dr. Lawson, final comments?
Very quickly, I just want to note that one of the interesting finds that that several groups are doing is actually using vaccination to treat addictions. There's one of the efforts to try to do that with cocaine use. The data is promising. Don't know how useful that's going to be. Secondly, I've been working with Dr. Hunter Adams. We're planning to do a session at the National Medical Association looking at the role of psychedelics and their therapeutic benefits. And that's an area that just has been understudied, and some of the new findings I think are very, very promising.
Thank you so much. Dr. Hines.
Well, this was such a rousing conversation and a timely talk, because again, holiday time is oftentimes an increased time for more substance use. So I really look forward to the directions that will go, and Merry Christmas to everybody.
Merry Christmas.
By the time we see each other again, it'll be past time. So that's it.
Dr. Ivan Walks.
Dr. Maxey, I would like to yield half of my final comment to Dr. Sherrod, who has had her hand up for the last few minutes, just to give us a little quick input, and then I'll make a comment after, if I can do that.
Dr. Sherrod?
Oh, good afternoon. Yeah, this has been an excellent session, and I just wanted to add in that we just had a session, ABWP, with Amgen and BlackDoctors.org on how to get more Black practitioners into clinical trials. So Amgen actually has committed itself to training private practitioners how to be PIs on cases. So when you put this group together, can you include ABWP, Association of Black Women Physicians? We just had the conference yesterday. So we need more, like you say, we need more Black data so that these drugs are more appropriate for our genes. And I want to commend everybody on all the comments. It's been a wonderful session, and Happy New Year, Happy Kwanzaa, Merry Christmas. Thank you.
Dr. Walks.
Thank you. Thank you, Dr. Farad. Thank you, Dr. Maxey. Dr. Chapman, Dr. Lawson, Dr. Veal. This is such an important set of topics, group of challenges, group of opportunities for our community. I really appreciate us all being able to come together. It's such a blessing to know good people. It really is, because sometimes you feel like you're out there by yourself, just kind of swimming against the tide. And so it is a real joy to know that there are so many people who have like concerns. And the last thing I'll say is my church group of men, we meet every Saturday morning. And yesterday we talked about the troubles of the world, how difficult it is, how people are depressed this time of year, how people are getting shot and killed all over the world and what have you. And people had a tough time getting up for Christmas and getting in the Christmas spirit. And I was kind of harsh. I said, look, miss me with that. I don't go to anybody's birthday party complaining about how sad everything else is. Christmas is a time for us to show that on the inside of us, that old song, This Little Light of Mine, I'm going to let it shine. I am excited about Christmas. I don't care how many folks are doing crazy stuff. I don't care how unfair the world is. I'm excited about it. And I just want to wish everyone a very Merry Christmas. I don't care what the world is doing. Thank you, Dr. Maxey.
And thank you so much. Is Dr. Neighbor Stevens back? Final comments?
I see her still here, but she's still muted.
Okay. Well, as my final comment, I'm going to agree with Dr. Walks. And one of the things that I have been aware of, that's the time that Jesus Christ was born, is at a time when the Roman Empire was the master of the earth. And as he came in, they used the word very mean, meaning very poor. And they had his birth in a manger where cows eat straw and hay. And the main thing that we should have our mind on Christmas is not Santa Claus, but the spirit of the God of the universe, who is Jesus Christ, our creator. And I hope that he will take us through the holiday season. It's all right to give presents and have eggnog, but have your mind stayed on the real meaning and significance of the birthday of our Lord and Savior Jesus Christ. Thank you, Simon. Thank you, Dr. Walks. Thank you, Dr. Hines. Thank you, Dr. Neighbor Stevens, Dr. Chapman, and Dr. Lawson. Have a great, and Merry Christmas. Thank you, Simon. Have a good day.
Merry Christmas,
Thank you.
everyone.